Hi everyone, myself Dr. Manianda Prabhu, Emergency Medicine Resident, Government THOOTHUKUDI Medical College and Hospital. I am going to talk about airway management. Airway is a passage through which air or gas passes through during respiration. Airway is divided into upper airway and lower airway. Upper airway consists of nose, oral cavity, pharynx, larynx. Lower airway consists of trachea, bronchus and bronchioles. Pharynx is a muscular structure which divide of bony structures. So, in unconscious patients, it tends to be collapsible and airway will be not patent. That leads to airway obstruction and no passage of air. That again leads to hypoxia, hypercarbia, and ultimately leads to death. So, maintaining of the airway patency is a vital role in emergency situations. In this airway management, we are going to see about the airway maneuvers, airway adjuvants, LMAs, and endotracheal tube intubation. These are the things which will maintain the airway patency and open the airway for air passage. Airway assessment, we have to assess patient's airway is patent or not. In this, we have to first see, develop consciousness of the patient. Then, if the patient is able to phonate, that means patient airway is patent. Then, if patient is unconscious or oral cavity is filled with secretions or fluids that indicative of airway obstruction, we have to go for airway management. Now we can go for airway maneuvers. First we will see head tilt and chin lift maneuver. In this maneuver, we have to tilt the head and lift the chin to make the oropharyngeal axis of the airway to be in straight line. By doing this, we will straighten the oropharyngeal axis. This will prevent the airway collapse. This is contraindicated in suspected cervical spine injury patients. Then we will go for jaw thrust maneuver. So we have to place our fingers over the angle of mandible. Then we have to lift the mandible upwards. This leads to displace the fallen tongue to anterior and release the airway obstruction. In suspected cervical spine injury patients, the jaw thrust maneuver only indicated. Head tilt and chin lift maneuvers are contraindicated. Airway adjuvants, these are the devices used to open the airway. These include oropharyngeal and nasopharyngeal airways. Oropharyngeal airways, otherwise called as Rudolph's airway. This is oropharyngeal airway. This is available in various sizes with color-coded system for various sizes. It's inserted into the patient's oropharynx to make the airway to be patent. This is the Rudolph's airway or oropharyngeal airway. Parts includes phalange, biting portion, curvature portion, and the distal part or pharyngeal part. Inside there is a canal which will allow the air to enter and come out of the airway. Phalange will prevent the airway to enter completely inside the mouth. Then the biting part will prevent the biting of the patient, and the curvature part is aligned with the curvature of the oropharynx and tongue. The posterior part will place between the posterior pharyngeal wall and base of tongue. Appropriate sizes should be selected for each patient. This can be selected by measuring the distance between angle of mouth to angle of mandible. After selecting appropriate size, we have to insert the oropharyngeal airway. Initially, we have to insert like the concave portion should be faced towards hard palate. When the biting portion reaches the incisor, we have to rotate it to 180 degree. Then we have to insert it. This will keep the oropharyngeal airway open. Oropharyngeal airway can be used in an unconscious patient who does not have a gag reflex. And it also facilitates the suctioning through the oral cavity. Cannot be used in unconscious and semi-conscious patients. Next, nasopharyngeal airway. This is placed inside the nasopharynx to open the airway. Parts of nasopharyngeal airway include phalange and tube. Then there is a bevel tip. Then for this also various sizes are available. We have to select appropriate size for each patient. This can be measured by measuring the length between tip of nose and tragus. After selecting appropriate size, we have to insert the nasopharyngeal airway. Before insertion, we have to apply the lubricant gel to the nasopharyngeal airway. Then we have to insert the nasopharyngeal airway with the bevel end facing against the nasal septum. Then we have to introduce perpendicularly with gentle rotation with back and forth. We have to introduce fully. Once inserted, it will prevent the airway collapse. This is useful in conscious and semi-conscious patients with the gag reflex intact. This is also aids in suctioning the airway. Next, laryngeal mask airway. This is useful in places where the skilled trainer in intubation is not available, or used as an emergency airway in situations where can't intubate, can't ventilate. For this, we have to select appropriate site, which is indicated in tube itself. For 30 to 50 kg, it's 3 size. For lesser than this weight, we have to select less number. For more, we have to select more the number. Then the parts includes inflatable cuff, then ventilating tube, then a connector, then pilot balloon. Before insertion, you have to deflate the cuff. Then we have to apply the lubricant gel to the cuff. We have to hold the LMA like a pen, and we have to place the finger between cuff and a tube. Then we have to insert along the curvature of the heart palate, and we have to fully insert it into the. Disadvantages with LMA is inferior than endotracheal intubation in the view of prevention of aspiration. Then we will see about endotracheal intubation. Endotracheal intubation is a definitive airway. In this, we are directly visualizing the vocal cords. Then we are inserting the endotracheal tube in between the vocal cords until it reaches 2 to 3 centimeters above the level of carina. Endotracheal intubation, we need laryngoscopes and endotracheal tubes, then bougie and stiller. Laryngoscopes. This is the direct laryngoscopy, which have a handle and a blade. Handle will have the batteries to eliminating these bulbs. There are many blade types are available. Most commonly used blades includes Macintosh, which is curved blade, commonly used in adult. Miller, which is a straight blade, used in pediatric population and infants. McCoy, which is a modification of Macintosh, which has a lever and a movable tip. When we apply pressure over this lever, it will be moved and lift the epiglottis for better respiration. Okay. Then endotracheal tubes. There is different size of endotracheal tubes are available. Based on the age and gender, we can use appropriate size. It's commonly used endotracheal tube, which is made up of polyvinyl chloride. Parts includes distal opening for ventilating the lower airways, Murphy's eye, which is useful to ventilate whenever the distal opening is obstructed. Then the cuff, which is inflatable. This will prevent the aspiration of the gastric contents into trachea. This black marker is vocal cord guide. We have to keep this marker in between the vocal cords while intubation. This is the various measurements from the tip of the tube, which is in centimeter. This is a radio opaque line, which will visible in X-rays. This is an adapter to connect to the breathing circuit. This is a pilot balloon. This is to inflate the cuff from outside. When we inflate, this is how we have to inflate the cuff. For deflation, we have to release the air from this pilot balloon. This is another type of ET tube. This is a flexometallic tube, which is also made up of PVC, and there is a inner spring metallic reinforcement. This is useful in procedures where prone position is warranted. The normal tubes were inked in prone positions, so flexometallic tube is useful in prone position. Usually, flexometallic tubes are used with stillets. Before intubation, we have to load the ET tube with the stillet, and the tip of the stillet should be proximal to the tip of the tube to prevent the airway trauma. Then we have to fold the proximal end to prevent the displacement of stillet into the airway. Then we can change the position which favors the intubation. This is the bougie. It's made up of cortex. It has a 60 centimeter length and 5 millimeter diameter. The anterior tip should be curved. This is smaller than an ET tube, which is easier to intubate between the vocal cords than the ET tube. Once bougie is inserted, we have to thread the tube onto the bougie. Then we have to remove the bougie. Then we have to fix the tube. Then we will see the procedures of endotracheal intubation. The definitive airway. First, we have to position the patient such a way that patient neck flexion and extension at atlanto-occipital joint. This can be achieved by head tilt and chin lift maneuver. The neck should be flexed and atlanto-occipital joint should be extended. This can be achieved by head tilt and chin lift maneuver. Once we achieve this maneuver, the external auditory canal and sternal notch will be in at same level. We have to hold a laryngoscope on left hand. Then we have to insert right side of the mouth of the patient. Then we have to lateralize the tongue. Then we have to advance the laryngoscope. Once it reaches the vallicula, we have to lift the blade towards the foot end of the patient or roof. The movement should be from the shoulder, should not from the wrist. Once vocal cord is visualized, we have to insert the tube. Once tube is intubated, we have to inflate the cuff with inflating the balloon with the air. We have to check the tube position by 5-point auscultation. Advantage of endotracheal intubation is the definitive airway. It prevents the risk of aspiration. The disadvantage there may be a pressure necrosis over the trachea, where the trachea and cuffing is in contact. It's an anatomically oriented face mask which covers the chin and the root of nose of the patient. This mask should be applied over patient face such a way that there will be a good seal and there is no air leakage. Parts of this mask includes rim, body and connector through which the breathing system will be connected. Then applying of the face mask over the patient face, we have to keep the lower part of the mask over the chin. Then we have to fix the upper part over the root of the nose. Then we have to apply easy clamp technique. For that, we have to keep our thumb and index finger over the mask, and we have to give downward pressure to give the tight seal and prevent the air leak. Then our remaining 3 fingers should be over the bony part of the mandible, the little finger over the angle of mandible, then the middle finger over the chin, then the ring finger midway between the previous two fingers. Then we have to give ventilation through the face mask. If we accidentally place fingers over sharp tissue part of mandible, that leads to airway obstruction. So you have to keep our fingers over bony part of the mandible. This is the ambu bag used to give the ventilation through various airway devices like face mask, then ET tube or LMA. This is a fish mouth valve, and this is the one-way valve which allowing the air to enter inside the airway device. And then this is a pressure release valve. When the pressure is more, it will open and the air will come out of this. Again, here is another valve which also a one-way valve which allow only air enter from the reservoir source to inside the bag. This is a oxygen port. This is for reservoir bag. When we connect reservoir back to the reservoir port, it will give 100% oxygenation.